I'm Teresa Weir. I'm a psychiatrist with the Department of Psychiatry and the Chief of Mental Health Integration for UHealth.
And I'm Teresa Lopez. I'm a licensed clinical social worker, and I'm currently serving as the program director over behavioral health integration. So I oversee about 35 licensed clinical social workers integrated in all the primary care and specialty care clinics across the system.
Okay, so Teresa and I are mental health professionals, but we are not going to talk about any psychological theories or new research today. We are going to talk about numbers as it relates to mental health training. So numbers, statistics, and dollars. So let's get right into it. So the problem, as many of you are aware, of all the individuals in the US living with mental health conditions, in 1 year, 12% see a psychiatrist, 20% will see any mental health professional, but 60% of people with a mental health problem see no mental health professional at all in 1 year. Really, really tragic. So some of those patients do get treated in primary care and other settings, but only 20% of people treated for mental health conditions in typical primary care settings actually have clinical improvement. So why is this such an issue? I'm going to pick on psychiatry because I'm a psychiatrist. I'm not going to talk about any other mental health professionals. But psychiatry today, psychiatrists practice mainly in isolation. Almost all of their time is on direct patient care. So they really have very little time for coordinating care and getting involved in education. So every patient that's referred to a psychiatrist is a 1 hour evaluation. So what you end up with is these small patient panels and very long wait times, typically in the range of months, if not longer. So we're all involved in education. So training, of course, that is a solution here. We hear about that a lot. We need to train a lot more mental health professionals. And we do. And we graduate about 8 psychiatry residents per year here at the U. So let's say 1 year, we had all 8 stay in Utah and all 8 go into outpatient practice. This never happens, by the way, but let's say it did. Because of these small patient panels, one full-time equivalent of psychiatry, that's about 600 people that they care for in a year. So that's about 5,000 individuals in the community. That's great, right? Putting that number into context a little, this is our depression screening data just here at the U. In 12 months, we have about 25,000 people who have a positive depression screen. They don't all need to see a psychiatrist, of course, but last year, even for our top 4 referrals to behavioral health, we had 23,000 referrals. That's just at the U. That's not even outside in the community in Intermountain and all these other places. So all of a sudden that 5,000 number doesn't seem so great, does it? And it's also very costly, as you know, to train residents. So it cost over $3 million to train those 8 residents who can care for about 5,000 people a year. The reason I mention this is just because we can't just train more. We have to change how we are doing mental health training. It's very, very critical if we're going to address any of our access issues. So what are some ways we can do that? So these are our primary care sites here at UHealth, and these all have integrated care available now with social workers, interns, and psychiatry residents. This is truly team-based care where care can be available to a patient immediately. So these new treatment models address someone's needs right when they need it, often same day or at least the same week. Don't make them wait months for specialized care. We measure the impact of the intervention, and we found that by doing this, you can actually reduce disparities in who receives mental health care. That wasn't the intent of integrated care, but it's a great statistic associated with integrated care. So when Teresa sits down with her social work interns, I sit down with the psychiatry residents day 1, we tell them, you know, these are some of the common conceptions we have about mental health that we need to dispel here. So the first one is more treatment is better treatment. This is America. We think bigger is better. That's not always the case with mental health treatment. In fact, more treatment can be harmful, as we've seen with some recent celebrities. So patients always want and will engage in specialty mental health treatment. Even when access is not an issue, only 50% of people follow through with a mental health referral. Only half will go to at least one appointment. And then specialty mental health consistently demonstrates improved clinical outcomes. That could be true, but we don't really know because only 20% of psychiatrists actually use outcome measures to assess how their patients are doing and improving. And then for therapy to be effective, it has to be continuous and long-term. Most people make the most change in therapy after one session, one appointment. That's why it's so important that when people are asking for help, we don't tell them it's going to be a wait of months and months, that we help them right in that moment. One session. We have something also an SST, like Dr. Egan mentioned, single session therapy. So we train our trainees on that. So we just have to do this. And we do a lot of this reinforcing this concepts over the course of the year on the rotation. This is what the psychiatry rotation looks like. So MHI is mental health integration. So our first year, our third year residents are out in the primary care clinics. They're working with the care teams, the primary care providers and pharmacists and social workers, and doing some direct patient care and short-term consultation and getting some experience doing indirect consultation. In their fourth year, then they move on to an advanced rotation for 6 months. They do some e-consults and phone consults, but mainly collaborative care. So this rotation is all based on consulting on a patient that you're not seeing. So in collaborative care, we don't have time to go into the details of that today, but we staff about 10 to 12 patients an hour. Remember, I told you we can only see one an hour. So we're really expanding the reach. And then we do some mental health integration didactics a few times during the year. I try to get the residents to think about, you're doing great patient care for that one person in front of you, but remember there were 20 or 30 who probably tried to get that one appointment. So you have a unique skill set here. What are you going to do for that part of the population? Really trying to get them to think about this as kind of a population health perspective as well.
All right, and I'm going to just quickly touch on the social work training that we have in integration. So I have a number of different things on this slide, but one important thing to consider is that in social work training with our practicum programs, we're the only practicum that goes through the College of Social Work that trains our students in primary care behavioral health, which is the model of integration, working in a team-based environment in the medical model, and then also collaborative care model. We train them in behavioral health best practices that are dispelling a lot of the myths that Dr. Weir talked about, such as crisis intervention, health and behavior assessment intervention, SST, single session therapy, and brief solution focused psychotherapy skills. We also train them in supportive workflows that are functional within the medical setting, such as the warm handoff care model and just providing that same day intervention. We have a very structured practicum program where we're providing a lot of support through peer supervision, clinical and operational supervision, and we support them in doing an organizational project as well. So these are just some, accomplishments from our program. Since the program's inception in 2015, we've trained 26 graduate practicum program students. And many of those we've hired, almost 10 of them have been hired post-grad. And we've put through 15 that have gained their full licensure while working in our program. We won the Practicum Agency Award in 2022, and we helped present in one elective class for behavioral health integration that exists. We'd like to incorporate more education in the College of Social Work for sure. in the future. As far as the organizational projects that we've supported people in 2017, we developed the Redwood Community Garden. This is a picture of us developing that with patients. That was a really great project one of the students came up with. We've done a number of provider satisfaction surveys, which is really important to measure the impact of the care in the medical setting, developed onboarding handbooks and an external provider directory. And we do a number of different things with cross-disciplinary training as well. So to kind of circle back, expanding the reach of the workforce, both in social work and psychiatry, what we're looking at here is comparing integrated behavioral health to specialty behavioral health, and the number of patients that can be seen in collaborative care is about 900 a year by a quarter of an FTE of a psychiatrist compared to the 600 patients for a full-time psychiatrist in specialty mental health. As far as unique patients seen, one therapist can see about 600 unique patients a year, whereas in traditional mental health, one therapist will see about 100 patients a year. Our referral lag is down to 17 days, whereas in specialty mental health, it's out past 70 days. And we do have outcomes in collaborative care where 74% of patients enrolled have had clinically meaningful improvement.
Well, I started with where psychiatry is today, and this is where I hope it is in the future, where we're much more collaborative across primary care, working with specialty mental health teams, and even getting involved in community outreach. I think this is a really important future aspect of mental health, is to get involved in mental health prevention. So thank you very much for your time today.